I think I promised in the introduction that I was going to talk about lumps and bumps and how to differentiate between benign and cancerous and give you all the secrets. Well, I might get to that bit, but I started this talk and realised I was going down this big rabbit hole of stuff to do with artificial intelligence. And I thought, I knew that some of the people in the audience would be of a similar age to me, and they might not really understand all that either. And so as I was learning all about what was out there, I thought I'd try and share at a very, very basic level about artificial intelligence and how it's affecting our lives, medicine and ophthalmology, and what implications that might have. So there is a whole lot on lumps and bumps at the end, but we'll see how we go. And if it's really stuff that you already know, feel free to go, yeah, you've got it all wrong, or no, what about this? And okay, that'll do. Because this was a patient that had been referred in to me just recently, and this patient was referred in for nothing to do with their lid lesion. They were referred in for a completely separate problem, cataract or something else. And I said to her, well, what about this thing on your lid? And she said, oh, well, that's been there for a long time, and I've seen several people about it, and everybody's told me that it's a blocked tear gland. And I looked at the referral and I thought, oh, look, they've noticed this lump, and there we are, there's a blocked tear gland. And I looked at it and I thought, oh, I don't think that's a blocked tear gland. I think we better biopsy that and have a look. And sure enough, this was an infiltrative BCC. And so this lady, I should have put a post-op photo up, but she's now had to have her entire lower lid taken off all the way along here and a reconstruction done from the top part of her lid. But as I was looking at it, I was thinking, gosh, it's pretty tricky, you know, that's a very subtle change in the eyelid, and, you know, how can we make it, what's going on? And is there an app out there that I can, you know, take a photo of it on my phone and go, yep, that's cancer, you need to refer it, or no, that's not cancer, you don't need to? Can we save ourselves and the patients, you know, can I save having to biopsy the ones that are normal and don't need the biopsy in the first place, and can we work out an easier way of referring them on? So that was kind of where I started from with the talk. And then I thought, I wonder about other things like these discs, because we look at discs all the time and we go, oh, that disc margin, man, it's a bit blurry up the top there, you know, is that swollen, is that a drusen, has that person got a brain tumour, and if I don't send them to the ophthalmologist, are they going to die? You know, it's kind of life and death decisions that we're making about these quite subtle findings. So that's where I started from. It's like, I'm going to find the answers and I'm going to put the names of the apps up so that you can all go home with the app and everything will be sorted. It didn't quite work like that. So I found an abundance of stuff on the internet, as you would expect, about artificial intelligence in healthcare. And there's lots and lots of these sorts of diagrams with lots of trade names and product names of all the things that are available in all these different categories where artificial intelligence is playing an integral role in developing these things and making it easier for us to make a diagnosis, sort out a referral, treat a patient, measure the outcome, correspond with each other, share information. All of these things are part of what's going to make our lives easier and more efficient. So very back to basics. And as I say, some of this will probably be very well known to all of you. But artificial intelligence, basically it just means something done to accomplish a task that's done mainly by computer. So it doesn't even have to be completely done by computer. And the purpose of it is to make computers mimic human thinking and improve work efficiency. So it includes things like simple automated detectors, machine learning, deep learning, and analysis of unstructured data. So from a professional point of view, I think when you hear the word artificial intelligence, a little bit of you kind of goes, oh, what does this mean for me and my job and what's going to happen in the future? And this is an example of a patient having robotic surgery with the Da Vinci robot system. So this system is now used in multiple countries around the world, including New Zealand. There's several of these in New Zealand, and this is robotic surgery that's done for general surgery, so things like bowel surgery, cardiothoracic surgery, obstetrics and gynecology, well, gynecology, not so much the obstetrics part, lots of urological procedures, pediatric surgery, and the number of procedures that can be now done by robot rather than entirely human hand is absolutely enormous. So this is really, there's two different types of robotic surgery. This type of robotic surgery is where the surgeon is still in control and still holding on to the pieces or controlling the surgery from afar. Oh, I thought I had another picture in there. So the surgeon might sit in the console and control the robot and make the robot do things, or the surgeon might be on the end of the instruments and holding onto them, supporting them, choosing which end to use, and the robot's doing all of the fine, delicate, intricate decisions and manoeuvres to try and improve the safety, get rid of tremor, especially for anything that's fine and detailed. And the idea is that this is going to improve outcomes for patients. So it came about largely from prostate surgery, where they were trying to preserve the nerve function to improve outcomes for people. Then there's autonomous robotic surgery. So this is when we let robots make the decisions and do the surgery themselves. So I'm not sure that we're ever going to get to this scientific or sci-fi kind of world where there's no one in the operating theatre apart from the patient and the robot. But you can imagine that this is not that far away. They've already got robots that can manipulate soft tissue and close wounds by putting in sutures, all on their own, without any kind of human interaction. And these are being used in clinical trials. So what about ophthalmology? What are we using robots for in ophthalmology? Well, this is quite astounding. So this is the first human clinical trial that's being done at the moment in Rotterdam on patients for epiretinal membrane peels by robot. So you can see that things like vitrectomy surgery would lend themselves really, really well to robotic surgery. Fine, detailed surgery on a delicate part of the eye where it's essential to not touch that macula. So I don't know, you've probably seen lots of videos of epiretinal membrane peels or know what's going on. I'm no expert, never done one, never intend to do one. But what we do to make it easier as ophthalmologists is put stains in to make sure that we can see this epiretinal membrane. And then these are instruments that are going in and peeling off this very, very, very fine layer that sits on the surface of the retina to remove the membrane. And you can imagine, so the membrane's actually invisible most of the time when you're in there, hence the use of the dyes. But you can imagine that it doesn't take much to just touch the fovea where you don't want it, or just touch a blood vessel that's going to cause a bleed right under the fovea. So using a robot that can absolutely manipulate and get just that finest layer is going to probably provide some increase in safety and outcomes for the patients. So what do we currently use artificial intelligence for? Well, these robot-assisted surgeries have been conducted successfully. Certainly makes the doctor's work more precise and effective. At the moment, the majority of these are done with the surgeon still in the room and controlling what's happening. The prospect of being able to do that by telemedicine and control these robots from far away also makes the option of having more people improve the equity of healthcare. If you can have a surgeon that can sit in a room anywhere in the world and control a robot and do an operation, then potentially you need fewer of these people to do all of these kind of surgeries. And this is the sort of thing that's likely to come in the not too distant future. But really, the main thrust of AI-assisted things at the moment is in medical screening and making a diagnosis. So this is because of the huge amount of imaging that's available and computers that can process and learn from all of these images. So melanoma can now be diagnosed with a computer algorithm based on macro images captured by a common camera. The problem is, it's not very good at it yet. Not as good as us. So it'll get there, but not yet. So how does it work? So machine learning is the ability for computers to learn without being explicitly programmed. That means that you're telling them something, they're repeating the task, and then they're learning as they go so they can do more than just the task that was given to them in the first place. So these algorithms are designed to adapt in response to the data being presented. So they can make predictions about something based on those parameters that you've given to them. And it's been around a long time. In 1956, a computer machine learning program was designed to win the World Championship checkers tournament. There you are. So this enables computers to make predictions by repeatedly learning stuff that's shown to them. So you need lots and lots of data to train the computers up, and the data that's presented to them needs to be labelled, so it needs to know exactly what you're giving it to it in the first place. So you've got to give it a whole lot of images of an optic disc that say this is normal, with as many different parameters and as much different normal as you can. And then you've got to go and present it heaps and heaps and heaps and heaps and heaps of information that says this is an abnormal optic disc, so that it can start to learn the difference between them. So that's reasonably labour intensive and still requires experts in the field to be able to work that out in the first place and tell the machine what it's doing. But once it's done all of that and learned all of that, you can present it with an image of a disc and it can separate those out and tell you, even if it's an image that it hasn't seen before. So it's not relying on the pattern recognition of exactly the images that it's had. It's learning so that it can use that information for a unique and novel image that you can then present to it. So once you've trained it, put anything in you like and it will be able to tell you. Once it's done its training and learned all this stuff, you then need some way of validating that that's true. So there's a process that you've got to go through where you then present it with novel images and an expert still assesses that and decides that that computer's actually got it right. So that's sort of the first group. And then there's this deep learning that goes on. And this is where it gets even more complicated. And again, no expert, trying to keep it simple. So this is when even more data is presented and even more connections are made for computers to be basically able to start and tell you stuff that is completely novel and unique that it's never didn't know anything about at all before. So this is where these developments of these convolutional neural networks develop, and they're kind of like a whole lot of little connections where you give it some information, you give it some more information, and it extrapolates that all out and makes all these new connections, just like a brain. So where do we see this all happening at the moment? I mean, there's loads of examples in modern day life. So the speech recognition in Siri, and there's lots of other examples of that as well. Language translation algorithms. If you put a photo of your dog into the computer, it will tell you what kind of breed it is. Can even work out these fancy designer schmoodles and snoodles and whatever else they are. Things like algorithms to predict the periods of high demand in a taxi, how to work out the route your Uber's going to take so it can tell you before you order it how much it costs. Google Maps so that we can get there instead of going around in circles. Some of us need that more than others. Spam blockers. Plagiarism checkers. These days it's pretty tricky to get it past, just printing off someone's work and handing it in. You certainly can't just get lots of stuff off the internet and hand it in and pretend that it's your own. It's pretty easy to check how much of that content is exactly the same as what you've submitted. Chatbots, virtual assistants, manufacturing robots. So these days, lots of production lines, any kind of task that's repetitive is done by robot instead of human. What about vacuum cleaners and lawnmowers? You can stick them in and leave them all day and get home and your house is clean. Social media monitoring, healthcare management, financial management, online shopping, and self-driving vehicles. And for those of you who didn't know that this is alive and well, even in Christchurch, this is the lab in Lincoln. So this is the Nurse Maud building down here. If anyone's from Lincoln, this is the lab pizza restaurant down here. My dad is standing about here with his cell phone. Summoning his Tesla to him so that he can get in and drive it away. Yeah, it does it all. You'll be pleased to know that the software only works in private land, so you can only make it summon and drive on its own if it's not on a public road. However, the autonomous drive function actually does work on a public road as long as there's someone sitting in the driver's seat. So if you're sitting in the driver's seat, you can make it drive you around, but it's a very unpleasant driving experience because the way that the Tesla works, when you accelerate's great. When you take your foot off the accelerator, it literally just stops. And so because it's designed to try and find all these things on the road that might be a problem, like pedestrians and bikes and other cars, as soon as it senses anything in the vicinity, it takes the power off. So you're driving along and as soon as it senses something, it stops. So it's not a very pleasant experience. But this is alive and well and here. So what about in medicine? IBM Watson is something that you might have heard of, and everyone thought that that was going to be the next thing. And IBM Watson is basically a huge, massive megadata system, and it was going to answer all our problems. You'd be able to tell Watson that you had a patient in front of you and they had distortion and they had a sore eye and they had whatever else was wrong with them. It was going to spit out and tell you, I've been through and processed all of this information and your patient has X, Y, or Z. And it's pretty good at some things. It can diagnose a pulmonary embolism, and it can be used to monitor malignant tumours, and other examples of AI in radiology are certainly up and working. I was going to talk a bit more. There must be another slide coming about Watson and how it really hasn't led to being quite as successful as what everybody thought. But where did all this start from? It came from putting this photo in of the tumour in the eyelid to convince everyone that it was a BCC rather than just a meibomian gland, a blocked meibomian gland. So how does it work in dermatology? So we often miss skin cancers because we think they're harmless, or we do biopsies or take out lesions that are harmless when we shouldn't need to. There's also far more demand than there is supply worldwide for almost everything in medicine. So these neural networks have been trained using thousands and thousands of images of skin lesions to be able to assist and detect the diagnosis of skin cancer. However, the dermatologists are still coming out on top. In the studies that they did, the sensitivities, which is picking up a positive result, so if it actually was a skin cancer, the sensitivity for these computer programs and apps that are available on the web ranges from 7 to 73%. So I'm certainly not confident that I want to use one that's at the 7% end of the spectrum, but I'm not sure I'm 73% happy if something's going to tell me whether it's a melanoma or not either. They are, however, pretty accessible, and you can use a smartphone and take a photo of a mole, put it in through an app, and it will tell you whether it thinks you should go off and see a dermatologist or a GP or someone and have it looked at. So when the learning and the imaging and all of these algorithms improve, it's certainly something that may well be out there. I'll talk a little bit about the limitations of it later, but it seems that the problem with most of these things is that they're good at saying yes or no. So they're good at telling you, yes, that's a melanoma, or no, it's not, but they're not good if there's a bit of nevus and a bit of melanoma, or if there's if there's more than one pathology, or if it's something that's not a yes or no answer. So it's being used in pathology a lot already and in clinical practice. So at the moment, if you've got breast cancer, you need to go and have a biopsy. They take a piece of tissue, they put special stains through it, they process it, and they look at it down a microscope to try and detect that malignant tissue. So Google has developed this deep learning program that can detect small tumours in the microscopy images with a detection rate of 92.4%. So this is getting up into the levels that we feel a bit more comfortable with. 92.4% of the time you're getting the breast cancer. Shame if you're the 7.2% that got it wrong. However, when you compare that to pathologists looking at it, there's not that much difference between them. So you can imagine the implications if you can still have a whole lot of people that can take biopsies, but they can then take a photograph of them and a computer program can tell you whether it's right or not. That's a big chunk of the workforce that we don't need anymore. Much more accessible for people to get the answers they need for things like a biopsy. Watson, here we are. So basically the idea was that patient would come in and tell you all these things, and you'd tell Watson that this was what was wrong with your patient. Watson would screen through every bit of data that was available on the internet. It would go through clinical trials. It would search through patient records, their own patient records, and find all this information. And then it would even look at results and tests and everything else that had been done for that patient or anyone else with these sorts of conditions. And then it would tell you, I think this patient's got breast cancer, I think this patient's got an epiretinal membrane, whatever it was. And so back in 2016, when this was all first coming out, it was met with great enthusiasm and the share price rocketed and it was sold for billions of dollars, and then it went down the gurgler because it really can't do what it was supposed to. Some of the issues with it were that it could the access to the notes, so privacy problems, being able to connect to different systems and get the information that it needed. The infrastructure and the technical stuff is just not there to be able to do this at the right level yet. So there are some sites still using this, but the problem is it led to lots of misdiagnosis. It took a lot longer than it was supposed to, and critical things were missed. And what they discovered is that it led to a de-skilling in the clinicians that were involved in using it as well. They started to rely on the computer and what the computer was telling them and trust the computer over their own clinical skills and judgment. So what about ophthalmology? So we can use AI to already look at fundus photos and OCT images to be able to detect cognitive impairment, dementia, Alzheimer's disease, and stroke risk. Already, and there are clinical trials that have been done that show that these images and this testing can help to lead to a diagnosis of these conditions. So imagine what that could do. If you've got the patient in there, no longer do you just have to refract them, you've got to tell them that they've got to go and see their GP and have a dementia test, because you can see that in the back of their eye, their blood vessels are of such a diameter that they're at risk of developing dementia. So these AI techniques that are around are going to enable us to make medical and diagnostic assessments and analyse this imaging to make a diagnosis or predict a disease course. So this is a little graph showing you the sorts of conditions that have appeared in the literature based on artificial intelligence. So you can see it was sort of around for a while, and now look at the exponential growth and all of the studies that have been done using artificial intelligence or programs to do it, to access and improve ophthalmology. So I guess at the basic level, it's teleophthalmology. It's being able to look after a patient somewhere else, have someone come in, through a computer, assess them and see them somewhere else. I'm sure you're all aware, but artificial intelligence is really already in clinical practice in lots of the world for diabetic retinopathy. It's being explored in a research setting for glaucoma screening, ROP, ARMD and oncology. And remote screening certainly has the potential to be of huge benefit to large populations if we're trying to detect disease. At the moment, you know, teleophthalmology could go around with big screening trucks, take images of people, and then you could transfer those images somewhere else for someone to analyse them and make a decision. And that was really where it all started from, because that's what was going on. It's what we do here locally. You know, you see the patients, you take images, you grade them, you send them in for an ophthalmologist to take another look at. It's not very much of a step for all of those images that are already being stored electronically to be analysed by a computer instead of a person, and for it to spit out an answer. Yes, there's diabetic retinopathy, rescreen in 12 months. Yes, there's maculopathy, refer to an ophthalmologist, with no person ever involved apart from organising and taking the image in the first place. So ophthalmology is really a huge area for all this AI and large data. I mean, think of all the thousands and millions of images that are taken, fundal photographs, visual fields, OCTs. They're all stored in an electronic medical record, or they're stored in image databases, or they're stored in viewing software systems. So if we can link that all up and get that data, there's a plethora of data that can be used to build these algorithms and try and work out how we can do better at detecting disease progression and hopefully working out whether our treatments are any good or not. So just thought I'd show you what was going on with diabetic retinopathy. So this is the IDXDR, and this is a machine that you can buy. The ladies emailed me. I went onto their website and went, hello, I'm a doctor in New Zealand. Can you let me know about this IDXDR? 17 countries around the world are using it. Come from the States initially. It's safe, effective, low-cost, autonomous, quick, acceptable to patients, users, clinicians and regulators, according to their website. So this is their pitch for it. So basically you have an ordinary fundus camera, and there are two specific types in the US that have been registered as compatible with this. So there were two Canon cameras in this particular example. You have a trained operator who captures two images that have been specified. The images are submitted into the system, and the system analyses the images for signs of diabetic retinopathy, and in 30 seconds it tells you the results. You've got the patient in front of you, you can tell them straight away, yep, you've got retinopathy, we need to see you in 6 months or refer you on, or no, you're fine, come back in a year. All of this data is on 12 months recall, because that's the standard of care in the US. So if you've got you've got diabetes, you should be screened 12 monthly according to the recommendations from the American Academy in America. And as I say, it grew from telemedicine because these patients were already having their photographs done and it was already being sent to an ophthalmologist. But now it's just assessed by the computer in the office. And it was developed in conjunction with IBM. It's FDA approved and it's used in 17 countries already. So is it any good? Why are we using it? There were some reasonably small trials really compared to the number of patients with diabetes that are screened, but there were 915 participants in the sort of landmark trial that shows that it's being used by things like the FDA to approve this. So these patients had 2 retinal photos analysed by the system. Then they were dilated and they had 4 wide field stereo photographs analysed by expert graders. So you've got the computer that's getting 2 undilated, pretty crappy images, and you've got the expert that's getting 4 wide field, dilated, stereoscopic photographs. So it's pretty unfair comparison already. But for mild diabetic retinopathy, the computer got it right 96% of the time. Okay, 88% of the time, the specificity measures its ability to not detect disease when it's not there, if you like. So it would say that there was a problem when there wasn't, if the specificity is low. So for vision-threatening diabetic retinopathy, 92% of the time it got it right, and 88% of the time it said there was a problem when there wasn't. All eyes with severe disease were detected. 90% of patients were tested without dilation and had photographs that could then be analysed by the computer. And 90% of the images taken were deemed gradable by the computer. So that's pretty good. So what about OCTs? I mean, they already are programs that can grade the severity of the macular degeneration on an OCT and fundal images using these algorithms. So machine learning already exists to be able to determine the progression on a spectral domain OCT. So for example, there's an algorithm that's being used in clinical practice that can look at patients who've got an image like this, and it can assess their drusen, it can look at the thickness of them, the number of them, the size of them, and it can then quantify them using an OCT and track changes over time, and it can tell you, you're likely to go on and get neovascular macular degeneration, you need to be reviewed X number of months, or these drusen are actually not that bad, you're going to be fine, you don't need to worry about it. So if we could predict when we saw these patients at the start which ones needed to be seen more often, we might be able to tailor our reviews and help to see more people. If we could prevent patients from going on and getting ARMD like this, we might be able to stop people going blind. So I guess the next step of that is working out how often we need to treat them, whether they're under or over treated, which if we could have an algorithm that could say, you're fine, you can wait 3 months before you need another injection, or no, you need to come in every 4 weeks and have one. But you can also imagine that this could lead to the day where you might be able to walk into the mall, put your head in an OCT machine, a scan gets taken, you sit back, it analyses it, it says, yes, you've got macular degeneration, yes, you need an injection, move to the next booth. Passing the cashier, handing over your money, you move along, you put your head in, a needle pops out of the machine, injects your intravitreal injection into your eye, you step back, you move over, you get your appointment to come back to the mall in 3 months' time. Maybe they won't need us at all. So does anyone know what this is? It's not macular degeneration. That's a clue. Probably something that none of you have ever seen apart from in a book. It's a very small little eye. Yay, it's ROP, exactly. So ROP is one of these devastating diseases that can still lead to blindness in children. It's really, really, really hard to look at these tiny little babies and look at their fundus properly and try and see whether they've got ROP. And part of the problem with ROP is that it tends to happen in the periphery of the retina. So when you've got a little, 32-week tiny little baby and you're trying to get something in there and try and get through the pupil and look out, it's not that easy. So if we could find something that could grade and assess the progression of things like ROP, we might be able to make a massive difference in the world to how many babies are going blind. And at the moment, there are systems that can analyse and grade it, but the problem is this complexity again. So these systems are all very good at saying yes or no, but they're not very good when you say, it's ROP, but we only care if it's more than 3 clock hours, and if there are blood vessels that have got tufts on them, and if there's hemorrhages, and if the posterior pole is also engorged. It can't analyse that complexity of data and add all of those different factors together to be able to give an accurate assessment compared to the current knowledge that we have. So if you just said to it, I want to know if it's got plus disease, which is a variant of a more severe form of ROP, where the disc is engorged and the blood vessels are big and swollen, you can put this algorithm on there and this computer can look at it and it can go through very accurately and say, yes, there's plus, no, there's not. So it's not going to be long until these systems will be able to be developed and these algorithms will all talk together and be able to do this sort of thing. But at the moment, it's good at that yes-no binary decision making, but not anything more complex than that. So glaucoma suspects, I mean, again, this would be great. You could have a patient, put them up there, you've got your high myope whose disc looks terrible and their RNFL is all slightly thin and their pressures are 19, and you think, they got glaucoma, or is this just, nothing to worry about? So we've got this condition, which is we've got multiple images for. We've got OCTs, visual fields, disc photos. Surely can't be too hard for these computer models to be designed to be able to differentiate between healthy glaucoma suspects and those with glaucoma. And they can do that, and they can even use these to include things like IOP and corneal thickness if it's been measured, to help us improve our accuracy when we're diagnosing early glaucoma. But the complexity of all of these factors, again, is a little bit of a challenge for these systems to be able to get something that's up and running and useful in clinical practice that is more accurate, or at least as accurate as we are. What's this? More ROP. Any takers? No? It's a choroidal neovascular membrane. Okay, so I'm sure that you all know that this is either a really, really big nevus or a melanoma. And of course the challenge is to work out with all of these pigmented lesions exactly the same thing. Is this a nevus or is this a melanoma? So we come up with all these acronyms. We know about 2 fine small ocular melanomas and how to look at those factors and decide, and yet still we're only about 30% accurate if they've only got 1 or 2 of these features, and obviously the accuracy goes up as we get more, but the consequences for this patient of whether this is a nevus or a melanoma are quite massive. So if we could run something through that's going to tell us, yep, you've got a nevus and that's nothing to worry about, with much more certainty, that'd be good for all of us. We can't yet, but this is what I want. Okay, so what about IQ? You guys know about IQ? Everyone's shaking their heads. You don't know about IQ? Not one person in the room's heard of IQ. I'm amazed. Okay, so what do you think IQ might be? What about refraction? That's right. So IQ, so this is an online autorefractor that is available in this, well, actually no longer available in the States because of massive pressure from the optometry community to shut it down. But basically, this is an online autorefractor. So you sit at home and you download this app, you load it up into the system and you look at these various things on the screen, and the computer analyzes your eye movements and the shape of your eye and somehow does something clever. By the way, you buy this special other device thing. Can't remember what it's called. Something that you've got to buy as well that must do something too, some kind of mini refractor thing or something that you hold up. And you do all these tests, and when it's stable and accurate, it spits out a refraction for you. And then, of course, it feeds you off down the line to the place where you can get your glasses and send you out these glasses. So you use it with a smartphone. You buy this personal vision tracker, and at the time that it was available in the States, and it was for a couple of years online, was $45 to buy this tracker, and then you could do 3 tests. Well, you had to do a minimum of 3 tests that were within a certain level of tolerance for the computer to accept that that was an accurate refraction. And then you'd link it up with a spectacle dispenser, and they'd send you out your glasses. So it's been available since 2017. It had quite variable reviews online, from this is the best thing ever to I had to go to the optometrist because I couldn't see when I got my glasses. But it's just a sign, I guess, of the start of what's going to happen out there. There have been a number of similar products that have been available. There's another one called Opturnative. If you've heard of that, again in the States. It was then rebranded as Visibly, and it was forced to withdraw from the US market because of pressures from the optometry community, quite rightly citing fears of the fact that there was far more to it than just getting a pair of glasses. So it's all very well to stick your head in a machine and get your glasses spat out, but if the fact that you've suddenly developed hypermetropia is because you've got a big tumour pushing on your macula, those glasses ain't going to be right for very long. So part of the issue is this whole idea of health checks and making sure that, you know, there is nothing else going on with the eye. And then, of course, there's the whole issue of liability as well, and where the liability lies with all of this. So if it's so wonderful, why isn't it everywhere? You know, first of all, we've got to worry about the safety of these things and how accurate they are. And are they actually more efficient, more equitable, and are they cheaper? Well, they're certainly not cheaper. Almost every single example that I've given you of something to do with healthcare is much, much more expensive than the alternative, at the moment at least. And as we all know with technology, the costs of these things when they're first developed are huge, but very quickly competition comes into the market, people work out cheaper ways of being able to do it, and the costs come down. But if you think of the Da Vinci robot, if you have a prostate operation and you have it done just in a normal way with a surgeon, the average cost of that in an American hospital is about $8,000. If you have it done with the Da Vinci robot, with the benefits that might come along with that as far as quicker recovery time and better preserved function, more accuracy, less bleeding, etc., you're looking at nearly 3 times the cost. So it's definitely not cheaper yet. There's also the issue of medical record regulations, sharing, privacy. All of these things rely on lots and lots of data being able to be shared amongst providers. We can't even get to the point where we can share a record about a patient here at the moment and have, an OCT sent easily from one place to another. And I mean by that something that's analysable and reproducible and something that we can compare to, because just emailing a copy of one isn't really the way that this is going to go in the future. There's also the issue of liability. I mean, what happens if a patient comes in and has their retinal photos taken and they sit at the machine and then the machine spits out something and says, you've got no diabetic retinopathy. Patient goes away, comes back a year later and they're blind because their diabetic macular edema was missed and nobody had picked it up. Is the person who took the images liable? Is the machine liable? Is the company that made the machine liable? Who's going to be responsible for, the care of that patient when things go wrong? So there's no answers to this, but these are some of the reasons that there's a lag behind them being developed in research and being available in clinical practice. What about cost and billing? How's that going to work? Can you bill for a test that comes out of a machine? If you're taking a patient's photos and spitting it into a machine, can you bill for that? And what about scalability? How is that going to work if we've really got this expensive equipment, lots of computers? Are we really going to be able to suddenly replicate that all around the country and all around the world? The algorithms themselves are absolutely massive and complicated to develop. So that's a big cost as far as just the computational costs and the experience of the people that you need to be able to develop them. Obviously, that's a one-off cost once they're all working and running. As I said before, the imaging that you put into these deep learning systems still requires experts to be able to go through thousands and thousands and thousands of images and label them all and analyze them all and detect all the abnormalities and tell the machine all of that, because it doesn't know that unless you tell it. And getting these images for analysis is difficult and not cheap. And of course, there's accuracy issues with these algorithms that might predict something that's not true. So, for example, there was a study that was done looking at patients who had asthma, and it was trying to predict those that would go on and need hospital admission or those that would be fine. And for pneumonia. And what it said was that if you presented and you had asthma as well as pneumonia, you were unlikely to die from your disease. But what it had missed out was that if you had asthma and pneumonia, you were much more likely to end up in ICU and have to be treated and have this really severe disease that required you to have a really prolonged treatment course. So it was kind of saying, oh no, it's all right, you've got asthma, you're going to be fine. But the reason you were fine isn't because you were fine, it's because you required all of these other things to be done that the computer hadn't been able to analyse. There's definitely this risk of de-skilling clinicians, which might not be important if the computers can do it all, but they've done lots of studies now where there have been systems put in place. For example, ECGs, lots of the machines these days, when you do an ECG, will actually tell you what the rhythm is and what you need to do, like the automatic defibrillators that are around in malls. If you see someone and they drop dead and you get the defibrillator out, you don't need to worry, you put the pedals on them and it goes into the machine and it says, this patient's in VT, you need to shock them and you need to do... So if you've got something that's telling you that all the time, you no longer have to analyse that information and make decisions for yourself. And when they were retested, it was found that the clinicians that were using these were less able to get it right later on than they had been before. Of course, there's the issue of clinical context. Oh, there we are. Asthma and pneumonia, because clinicians can use, we all use our experience and our knowledge and all of the other things that the patient are telling us to make our decisions about what's going on and what we need to do with them, but the computer can't do that. It only knows what you've fed into it and told it. Or then of course there's the limitations of the internet, electricity, countries in the world that don't have any of this, and even in our own world, you know, in our own country, the infrastructure is just not there to support this at the moment. I didn't really go into the difference with these deep learning systems, but there are two deep learning systems. One where you feed all the information in and you know the outcome that you expect, and the computer learns, and then when you present it another image, it can tell you what's going on. And then there are these black box systems where you're giving the computer information and it's learning all the stuff that you haven't really told it, and then it's giving you an answer, and you don't know how it's got from the information that you've given it to the answer. The answer's right, and it's what you wanted it to tell you, but the bit in between is all a bit unknown. And that's pretty difficult for us to trust as clinicians who want evidence and want to know exactly how it's got there. So there might be, people would be quite reluctant to accept some of this if it's not proven and shown how it all works. So, of course, the other issue is if we suddenly have a whole lot of these different algorithms and different machines, you've got one that detects diabetic retinopathy, one that detects glaucoma, one that detects melanoma. How are we going to fit all that together and make that work? Because all of these work quite independently at the moment. So you can't sort of put your patient's head and take an image and go, no glaucoma, no this, no that. You need to know what you're asking, and you probably need to have a whole lot of different systems to look for all of those things. So it's here, it's already a feature in everyday life, and in medicine it's already being used to help make a diagnosis. It relies on deep machine learning with complex networks of algorithms, and that's about as much as I get of how it all works. But it certainly has the potential to improve access for healthcare. It's already here for diabetic retinopathy, and it just can't be long until it gets here for that. But at the end of the day, none of us have got anything to fear. Maybe frightening for our children and grandchildren and what the future may hold for them, but this is all going to complement and not replace the eye care professionals. And so this is what I promised I was going to talk about, you know, how you tell the difference between this, and how these things that look the same are actually not. This one, who votes for this one's the cancer? Who votes for this one's the cancer? Who thinks I'm going to make it so obvious? Yeah, that's right. So who votes for this one's the cancer? Come on, it's like 50-50. This one's the cancer. This one's the cancer. So yeah. This is a cystic mole, this is a cancer. I was just trying to see how I could, sway you. But actually, at the end of the day, it's really very, very difficult to tell the difference between some of these things. So according to my time, I've still got 10 minutes. So for those of you who really wanted to know the difference between them, I'm going to whip through a few slides on actual lumps and bumps and how we tell, okay? But I promise I'll stop at 1:30. So what are we trying to work out? Is it benign or malignant? We can't use an app to take a photo and tell us, so we're still going to have to use the old clues. Ask, look, feel, and biopsy. So what do we want to know about an ask? Has it changed? Yep. What else do we want to know about and ask? Yep. Family history, yeah. Personal history as well, yeah. Yeah. Yeah, good. And what about some of the features that would make you worry? What symptoms might they have? Does it hurt? Do we worry about pain? What does pain tell us? Pain tells us inflammation, and what does inflammation tell us? Bad? No, actually quite the opposite. So usually skin cancers are actually not painful at all, whereas if there's pain and inflammation, I'd be much more thinking, oh, that's some kind of chalazion or something that's infected or something like that. Bleeding, however, is quite the opposite. So if you've got something that's bleeding and ulcerating, then we really want to worry. Some of these things are going to be sort of ubiquitous and always there, but sun exposure, have you spent your whole time working outside? Have you had radiation to that area? Smoking's just bad and a risk for everything. But the rest of them, you're quite right. So when we look at it, we're going to look for these signs: ulceration, bleeding, encrusting. And I guess it's the same with everything. When you've got something that's sitting on a lid with a big crust on top of it and it's ulcerated, it's got blood vessels around it and it's got a big pearly edge, you look at it and you go, that is bad, and you know what you're going to do with it. And it's not really those ones that concern any of us. It's those tricky ones in the margin that kind of you're not sure. So the heaped up pearly margin is the classic for the BCC. Is it irregular or diffuse? Is there changes in pigment within it? Are there blood vessels within it? I think that's an underestimated and really useful sign. So things that are benign and not really a problem don't tend to have blood vessels within them that you can see, and certainly not kind of blood vessels feeding into them, or, you know, and on the skin I'm talking about rather than the conjunctiva, although it would be true for both. And those who've been to my talks before know that I'm really, really keen on this one. And if that eyelid is not perfectly normal, then you need to worry, okay? So that first photo, and I'll go back and show you that at the end, if you actually look closely at it, you can tell that that eyelid margin has actually been destroyed. It's irregular, okay? There's still lashes there, but there are not as many, and they're not in the same line as where they should be. It gets tricky because blepharitis can do this and it can destroy the lashes, but you should never put blepharitis down as the cause of this until you're really absolutely certain that there's not something else going on, okay? And loss of lashes is, yes, absolutely it can happen with blepharitis, but until you're sure there's not something else in there, you need to be thinking, could this be something else? Often you can feel the lumps before you can see them, and they usually extend well beyond what's visible. What it feels like is quite useful. Is it mobile? Is it fixed? Is it firm or soft? For example, things in the eyelid, if you can put your finger on it and wiggle it around, it's probably not much. It may not be as worrying as something that if you put your fingers on it and feel it is rock hard and seems to be stuck to the bone underneath. You know, if it doesn't move around inside the eyelid because it's growing down and got attached to something underneath, then we're going to be more concerned about that. So we can do biopsies to work out what's going on, and there's lots of different ways we can do that. So we can shave something off the lid margin, we can excise it completely, we can take a little punch, we can do a wedge. And all of this is just to try and give us an answer at the lab. And at the end of the day, if I'm not sure, I chop it off. So there is no way to be certain about whether something is cancerous or not. These sorts of things, they're really tricky. So here we got something that doesn't necessarily have all of the features of something that's benign or malignant, and these are the difficult ones. So what am I worried about with this one? Yeah, so it's growing in the middle of the lid margin, and this whole area is absent its lashes. So as soon as I see that, I think, is it something going on? But what am I not worried about? The colour? Yeah. It's really, really well circumscribed. So it kind of looks like something that's just stuck on there. So it's really not diffuse at all. It's got no different colour in it. It's got no ulcerated centre. So it's completely smooth and flat along the top. It hasn't got an umbilicus or a little hole in the middle of it. Yeah. So it's benign, but I think that's a difficult one to be able to tell. You know, that could easily be a little cystic BCC. It could be something more concerning than that too. What about this thing? It's huge. I know that's mean, isn't it, that I put one in like that? Exactly, that's why I did it. So no, this is sitting in the skin, and once you lift it up underneath the eyelid, the lid margin's perfectly fine and normal, all the lashes are there, and Trudy's seen lots of these, so she knows it was it was a trick. But this is just an actinic keratosis. This is something that, you know, is benign, nothing to worry about. They always look like a plaque that's kind of just been stuck on the top of the skin. Most of the time, by the time they come to see me, they're pretty large and ugly and they want them taken off anyway, so it's easy for me because I can just take it off and send it to the lab and say, oh no, nothing to worry about. What about this? It was made a little bit easier because you can see the lashes coming down, so I agree that you can't see the lid margin, but let's just say that lid margin's normal. You know what? Be worried about this. So this is a patient, it's been there for 6 months, started off small, was just like a little pimple when it was first there, and it's got bigger, and now it's sitting here, but it's not bothering them, it's not irritating them, it's not uncomfortable, there's no pain, it hasn't bled, but their mum died of melanoma. So they're really worried that they're going to die of melanoma too. Are they going to die of melanoma? Not from this. So you've seen this. That's the history. Who's worried about it? Oh, it was started off as a pimple and now it's, you know, this big. What's going to happen soon? Anyone know what it is? So this is a papilloma. This is a viral papilloma, and they look like little clusters of grapes. They're quite a classic kind of appearance. They're the same sort of virus that causes warts and verrucas, so they're often quite multiple, and they get bigger and bigger. And often they're actually really quite annoying and quite ugly, so people want them taken off because of that, but they're not, almost never, something to worry about. There are some subtypes of HPV, which is the human papillomavirus that causes all of this, that do actually have malignant potential, but they don't tend to be the ones that form around the eyelids. They're normally more the ones that grow in the tear drainage system. No, so if you take this off and cauterize the base of it, they don't come back in the same spot, but you absolutely could get them elsewhere. So I always tell them, I'll take this one away, it won't come back here, but you might get them elsewhere. So these papillomas that we're talking about, there's lots and lots of different types of them. This is actually a verruca growing in the eyelid. It's easy now, you don't have to answer any questions for this one. But I put this up there because nevi around the eyelids often don't look like nevi anywhere else. They're usually these sort of pale, not pigmented things that are growing. And they also kind of break all my rules of what I said before, because usually what they do is disrupt the lid margin and make the eyelashes kind of grow all funny, okay? But what these patients will tell you is it's been there for years. You know, they might say, oh, it might have got a bit bigger, or it might have got a bit of pigment in it, or it might irritate them now because it's grown and enlarged. But they're always very chronic and been there a long time. So if you see something that's well circumscribed and it breaks all the other rules, but it's got a long history in it, and it's got lashes growing in it, that's another really useful sign. If it's healthy enough to be able to have a blood supply and to be able to maintain a hair follicle and let lashes grow within the lesion, then it's probably nothing to worry about. They tend to get bigger at times like puberty, menopause, pregnancy, so there's some hormonal things related to them as well. Xanthelasma, these are really common. I guess the main thing to tell you about xanthelasma, I mean, they have a typical appearance and I'm sure everybody will recognise them and know what they are. There's a common myth out there that this is related to high cholesterol and you need to be worried about patients' cholesterol. It's not true. So it's not, they are cholesterol deposits that have collected in the skin. That's what they are when you send them off and analyse them at the lab. But these patients almost always have normal cholesterol. The only association is in patients who have familial hypertriglyceridemia, which they almost all will know about anyway. So, yeah. So yes, see them, and yeah, they can be treated if they're annoying. They do tend to come back. They're always in this sort of medial orbital distribution, so you don't, if you see them out laterally and around the outer corners of the eyes, then I would be concerned, and I don't think that is a xanthelasma. While they can occur there, it's extremely rare. They're usually in the medial aspect of the upper lid, and less commonly but also frequently in the lower lids. And you can treat them, I say to patients when they come in and they don't like them, Well, there's 3 ways you can treat them. You can either burn them with the laser, you can burn them with the acid, or you can cut them out and get rid of them with the knife. And they all say, cut them out, but I think it might be partly the way I sell it. But you can actually treat them with acid or laser and reduce them over time. They tend to just go flat and pale and you can still see them, whereas when you cut them out, they heal up and look pretty good. Everybody probably knows what this is, but this is a child, multiple lesions. Usually they'll present to you because they've got a recurrent conjunctivitis and a red eye, and the parents will come in and say they just keep getting conjunctivitis. Yep, I'm sure that's what it is. So this is molluscum contagiosum. It's a common thing that we see, and it is this recurrent conjunctivitis. So they get this follicular conjunctivitis that they often present with, because most of the time the parents of the molluscum are everywhere and they've got 5 children who've had them and they've been told by all the GPs that they just need to leave them alone. It's a benign self-limiting condition. The self-limiting part seems to take a blimmin' long time, like months and months or even sometimes years before they go away. So if these kids are getting recurrent conjunctivitis because the virus is shedding and that's what they're getting a reaction to, then curetting them out is actually a good idea. So when they're around the eye, I do tend to get rid of them. They also can look a little bit like basal cell skin cancers. So they sometimes, if there's a solitary one, people can get a bit worried. And you do see them in adults as well as children if they haven't been exposed to it and they get them in later life. And they have this classic umbilicated centre, so they get this little hole in the middle of them. So when you see them in an adult, good question to ask is, have you got young kids and have they had other lumps and bumps on them? So these are the ones that start getting tricky. Like the one that I showed before. See this really commonly. It's nothing to worry about. It's just a little blocked gland. Stick a needle in it, squeeze the stuff out. It's like a pimple. It's quite fun. And then this, similar to that one before, hey? Actually, I don't think I showed you. Oh, it's all the way back there. Doesn't matter. So what do you reckon about this one over here? It's kind of big and obstructing the lid margin and destroying all the lashes and kind of looks nasty, doesn't it? But it's not. It's just a little sister mole. Sorry. It's not easy. It's getting easier, isn't it? We don't like the look of these. And again, these really I don't need to put up because these are the ones that everyone's going to look at and go, oh, I don't like the look of those. I need to send those on. This one bleeds all the time. This actually had a horn growing off it, so had a little keratin horn. The horn fell off. The patient came in and said, oh, nothing to worry about now, it's gone. But this is a squamous cell carcinoma. So this needs to be taken out and it needs a good margin. So this patient's going to lose most of their eyelid. This is clearly nasty and something that we're going to be worried about. Rapidly growing, bleeds, destroyed the lid margin. It's not hard. These are the kind of people that unfortunately we're seeing increasingly commonly. The problem with these patients is what's all over this patient. Yep, skin cancers everywhere. Actinic change everywhere. I mean, this guy needs a face transplant, which of course we're not going to be able to do. So it's about dealing with the areas that are the most concerning. So you can see from his eye what he was getting was exposure. He's got this BCC in his lid, his eyelid's been destroyed, it's all being pulled down, he can't close, he can't blink. Fortunately, we've got things like a micromod and Effudex now that you're bound to have heard of. So these are topical treatments for treating actinic change and superficial BCCs, and they're fabulous for patients that have these skin changes that are not invasive cancers. None of them are licensed for use in the periocular region, although we do sometimes use them. These are the sort of things that I was talking about before. This is what this other man would have looked like with this big keratin horn coming off the top. And I guess I really put this kind of picture in for the registrars because what tends to happen with these is that this comes off really easily. So you put the local anaesthetic in to do the biopsy and you take the horn off and you send the horn off to the lab and you test it. And that comes back as a benign lesion because it's just keratin and dead skin and nothing to worry about. But of course the problem is at the base here, because this is where the cancer is. This is what's causing the keratin to grow. So unless you take the biopsy from the base and get into the lesion, you're not going to get the answer. So just a few photos to finish off of the more classic things and what their typical presentation's like. And again, they're not the ones you're going to miss. This is the pearly edges, the ulcerated centre, the loss of the lid architecture, the abnormal eyelashes. This is the more difficult one to spot. You know, they tend to be a little bit subtle in the corner, but again, the pearly heaped up edges, this is not a great photo. The telangiectasia and this ulcer in the centre, that's the classic thing to look out for. You can see them anywhere. The lower lid's the most common, but you certainly get them in the upper lid as well, again, when they're terrible like this. Been there a long time. And back to our old friend, like the one at the start. So this one, I guess, looks a little more suspicious. I mean, for a start. So this is a recurrent BCC. It's come in an eyelid that's already been reconstructed. So the lashes are destroyed from prior surgery rather than anything else. But this, of course, is the area now that we're worried about. And the difficulty with this is where on earth does it start and end? You know, which bit's the lesion and which bit's the lid reconstructed and which bit's the tumour. So we, I should stop. Yeah, I should say, there's a warning on it, doesn't it? Sorry. There's different ways that we can do these surgeries, and one of them is with Mohs surgery. And the problem is the Mohs surgery is done by the dermatologists, and they basically cut out the pieces and assess them under the microscope at the time to work out whether there's any tumour in the edges, and then they keep taking more and more until the tumour's all gone. And then they send them to us to fix up. So the good news about it for the patient is that you keep going until all of the tumour's gone. Whereas when they come to see us, if we sort of had to cut out that much of someone's eye, we'd be feeling a little bit like maybe we can get away with not taking quite so much and hope that it doesn't come back. So this way they've got the best chance of all of the tumour going, with supposedly the minimum amount of abnormal tissue and normal tissue going with it. But sometimes you get some pretty big holes to have to fix up. This isn't projecting very well on here, it's much better on my screen, but this was just to say about pigmented things and how difficult that can also be. So this is actually a melanoma with a satellite lesion, so these can be pretty hard to spot. But I think everybody would agree that this is pretty irregular, very hard to work out where the edges of it. This darker pigment within a very fair skin is going to be something that you're all going to be worried about. So we go back to the end. And I tell you that one of these is cancer and one of these is not cancer. And actually, I don't expect any of you to really know because they look exactly the same. And the only reason I know, well, what's the only reason I know which one's cancer and which one's not? Yeah, because I've sent it off to the lab to find out. So unfortunately, no app out there to tell us. Are we worried about this? Or are we worried about this? No, yes, just to see if you were listening. And that's it. So I think I did it in, or not quite, 5 minutes over. So has anyone got any questions for me? Yes.
So we're really good at obviously manipulating these robots and getting them to move really slowly finally, but when we get the patient to lie equally still.
Right.
Completely knocked out.
Well, so at the moment, or when we're doing it with robots, or both, well, actually what we do now, so we used to, but now for vitrectomy surgery and even epiretinal membrane peels, we do it under an eye block. So we immobilise the eye, so it can't move, blink, the patient can't do anything. No. And I guess the thing is that you're taking away, so you may not be doing anything to influence the mobility of the patient, but you're taking away the surgeon factors that might impede your accuracy. Of course, the excellent vitreoretinal surgeons that we have working here have the most steady hands of anyone and would never have a problem peeling the epiretinal membranes away. So you can feel confident that even without the robots, your patients will be fine. They're pretty cool. So for everyone that's younger than me, which is almost all of the audience, AI, deep learning, machine learning, it's all just like rolls off your tongue and part of everything that you do. And writing algorithms in your spare time. No? I think you should be. It's the future.
Would you get a robot to do the incision for you?
Look, if robots can do something, better than what we can do it and can improve the outcome for the patient in some way, then, and it's going to be cost effective and something that, you know, isn't going to make the costs of healthcare go up astronomically, absolutely. I don't think we should be afraid of this technology and think that in some way it's going to replace us as diagnosticians and carers and, you know, people, and there's no way, at least in our lifetime, that this technology can advance to the point that it's going to be doing our jobs for us. It's going to make it easier for us to do our jobs and make it better for the patients to be able to offer the care that we need. I mean, everyone's busy, there's lots of patients not getting seen, and I mean, that's just here locally. If you put that onto a global scale and you think about what we could do if we could actually do what we're doing better and for more people, I think that's great. So would I let a robot do it? Yes, but I'd really hope that it was one of those robots that I got to kind of go with, and not one that just I left the room and it did it for me. Yeah.
With the xanthelasma,
yes.
With going, like, obviously if it reoccurs,
yes.
you know, going back to operate again, you know, is that something, how
well,
many times can you do it? Or
so I hope that when they come back, they've had a few years and they've got a little bit more time to stretch and get a bit saggier again, so that I can go and take a little bit more out. But yes, you can definitely go back and do them again. And the medial cancer is a very forgiving area, but it's also an area that scars reasonably badly if you're going out beyond the lid crease. So you definitely have to be careful. And if I'm redoing them, I'll certainly be warning them that I want to be confident that the improvement I can give them in appearance is going to be worth it for the scarring compared to what's there at the time. But yes, you can re-excise them.
And for like a resource for, I'll say, lid lesions, I know obviously we use smartphones to send stuff in for written advice and so on. But what do you recommend? Like, I know that I've used DermNet a couple of times trying to figure out if something's a nevus or not. But is there any good online resource, or we just need to go by our basics? And
I think so. I mean, there are a few clinical applications that are available that are trying to do this whole differentiating between a nevus and a melanoma, or tell you whether something is benign or malignant. The problem is that the accuracy of them is so poor at the moment that I would still trust your clinical skills more than what I would trust those applications. Yeah, so it's judgment, really. Yeah. I mean, anything that is malignant. So first of all, if it's a basal cell skin cancer, it's going to change usually slowly, so it can be a little bit difficult to predict what's going on, but it's also not going to matter if you miss it and if it's not treated for a long time. All that's going to happen is it's going to grow slowly and get a little bit bigger, and it's going to be obvious that there's a problem because it's changed. And the outcome for that patient is really, it might mean you have to do a slightly larger surgical procedure on them to remove it, but that's the worst that's going to happen for that patient, because basal cell skin cancers don't spread, don't go anywhere else, they certainly can't kill them. So those sorts of difficult ones like that, it's not going to be the end of the world. So looking for change and saying to the patient, you know, you've got something there, I'm not sure, it's possible that this could be something that we need to worry about, but we don't know yet. But it's very reasonable. Take a photograph of it, and you know, even on your iPhone now, the photos, the quality of them is really good. You can see them back in 3 months or 6 months, and take another look at it, or send them to their GP, or send them to me, or whatever. But I wouldn't be too worried. And the more nasty ones usually are pretty obvious. So I have had a couple of patients with quite nasty unilateral invasive basal cell carcinomas who are quite young. So 2 patients in their 30s who'd been treated for quite some time for really bad unilateral blepharitis. So I don't mean to harp on about the blepharitis, but if it's in one eye and not the other eye, that's probably a little bit of a warning sign. If one eye looks completely normal with lots of lashes and the other eye's got none, that's probably not blepharitis. So, you know, even though it was really hard to spot that it was a basal cell skin cancer, but yeah, so I'm not saying it's easy, but using those kind of common sense clues is going to be the easiest way to go. And fortunately for those patients, yes, it's a big operation to get it back and fixed and normal, but it's not a life-threatening thing. Yeah. So maybe that's helpful. Yeah. Cool. No other burning questions? Excellent. Well, thank you all very much for coming. The support is appreciated. And yeah, apologies again for the change of date. I think we're back to our usual Wednesdays from next month. Not sure what I can introduce for next month. Who's coming next month? No, sorry. A surprise. Some other kind of delightful talk. All right. On the thing with these lesions, if you're worried and you're not sure and you want to take a photo and email it through, I'm more than happy to take a look at them. And all the referrals at the hospital, you have to send an image. They won't get accepted unless you send an image with the referral to be looked at. Oh, yes. Oh, no. Yes. Oh, actually, I've got something to say about that too. Yeah.
And she was saying, oh, no, can you send me the photos? Have you got a WhatsApp group?
Oh, no. So they should not be asking you to send them through any kind of non-secure, so you need to send them on ERMS. Or you can, I guess, are you still using the email, the iClinic email as well for referrals? I mean, it's not the most secure thing, I'm sure, but if you want to attach it to that. But I will tell the registrars that, sending them by WhatsApp and sending them, text messaging them to their phones and things is not really ideal. We're not supposed to use it.
I didn't put it up the names and things.
Yeah. I guess the other problem is that if it comes through ERMS or it comes through the email, then it's stored in our system and there's a record there attached to that patient. And so then...
I did a proper referral.
Oh, right, okay.
She
Yeah.
just wanted to know how urgent that problem was.
Okay. I mean, I'd just stick with the usual channels because it is better if we have a record of it, and then if something changes, we've got the initial referral there. And even just from a liability point of view, again, not that we're looking into any kind of blaming of anything, but it's just useful if that information's all stored in the right way. That first photograph that I put up right back at the start of my talk was a disc. And I was, before I got trapped into the world of AI and got so interested in it all, going to talk a little bit about that, and David was going to talk to you guys about it as well. It's just to say that I know that the triaging system at the hospital is probably incredibly frustrating for you all when you send patients through and you really want them to be seen and you get back a, declined, and I think the word is something like meets threshold but not at no capacity or something like that. Things are pretty dire at the moment, and the thresholds for everything have just gone up again. So you probably heard that the cataract threshold's gone up, but so has basically the threshold for everything. And we're aware that as a result of doing that, there will be things that you're sending through in referrals where you really are concerned and there really might be a problem. And we're saying, look, at the moment, we don't think that that's serious enough to be seen. Please do re-refer them if you're worried and if something changes. And I realise that we're pushing the responsibility of following these patients up back onto you. But I know that we will get it wrong sometimes, and I'm happy to have calls or emails, or if you've got someone and you've sent 2 referrals through and they're not being seen and their disc's getting more swollen and you clearly have a problem, then we will listen. It's fine. Yes.
If they meet the threshold,
yes.
Are they still going into a pool rather than going into the system?
Oh, no. No. So if they meet the threshold, they just automatically get accepted.
Okay.
Yeah, and they get eventually operated on. Okay. Yes. Yeah. No, we're no longer using the pool.
Right.
Fortunately, the pool was a disaster for everybody. Yeah. Okay.
You sometimes get back through ERMS from the triage. That's been quite helpful.
Oh, good. Okay.
You can get their thinking.
Okay.
And even when the patient has got the letter saying we just don't have time to see you, so
yeah.
then they give you a bit of advice on how to look out for it.
Good. Yeah. So there's also been a bit of a change in triage at the hospital. So you might notice that you're getting things back from a lot of different people now. So we're all taking week turns to do it all. So that will be both useful and interesting, because of course we'll have people that are not used to accepting referrals on all these things. So you might see there's a bit of variability depending on when you send it in, and we have guidelines and it's all supposed to be adhering to those guidelines, but there may be a little bit of variability. But yeah, just if you're concerned, we do want to know about it, and please feel free to get in touch. And sending another referral through is not we know that you're not just sending it because you're being difficult, that you really are worried, and it's important. Yes.
How do we communicate through Zooms or otherwise if, like, say I've had a patient and some way through the referral they've changed their address and they wanted me to communicate that, waiting on further contact? How do we? That's one situation. Another situation I think was like they've been waiting and they haven't quite had a response. And they changed their mind and they want to go private. So then, how do we let you know that?
They no longer required. I mean, you can send anything through ERMS. So you can just send information in through ERMS, and there's a box that you can tick that just says information only or something. And all of it, at the moment, there's no filtering of any of that information. So anything that comes through ERMS gets loaded onto eTriage, and whoever's in charge of going through and filtering the referrals will get all of that information. So I just send it through on that. Yeah, anything. But I mean, if it's things like updating contact details, just tell the patient to go to their GP or ring the hospital, because the NHI lookup system thing is all linked. So as soon as you let one of those people know that your address has changed, it automatically updates it everywhere. So I don't think it's your responsibility to do that. You probably can you?
Can they just do it through the GP?
Yeah, absolutely. And if they do it through their GP, it updates through the whole system. Yeah. Yeah. Cool. All right. Well, thank you very much for coming. Feel free.